everyone. Welcome to the second webinar on unlocking the power of ACOs with Beth Paddock. Beth is our Executive Director of Government Programs and ACO Operations, and she has a wealth of knowledge about all things ACO. Beth, I'll let you kick things off.
Thank you very much, Alexis. Hello, everyone. I'm very pleased to be here. Go ahead and jump right in. You might be wondering a little bit about who is on Belay Health Solutions. Well, we are a national management services organization. You can see here on the slide the states where we are currently operating and some of the services that we offer. But I'm going to go ahead and just jump right in with a metaphor of what we're going to be talking about today. The Choluteca Bridge in Honduras. This is a wonderful parallel to what is happening with Medicare. Just to set the stage here, this was a bridge in Honduras where the country gathered the greatest minds to come up with an engineering marvel that would withstand any sort of hurricane. And they finished building it in 1996. In 1998, Hurricane Mitch, a Category 5, hit Honduras. The bridge withstood the hurricane and was basically untouched. But the river moved. This is what the bridge looks like today. And this is a really good metaphor for what is going on in Medicare. Our river has moved. When we think about when Harry Truman first called for the creation back in 1945, it took them 20 years to sign Medicare into law. They put the greatest minds to this project to make sure that we had a sustainable program. But today, where we are is the spending is out of control. It's more than 20% of total healthcare spending. And right now, the estimate is that the trust fund that actually pays for Medicare Part A is going to be depleted in the very near future. So something has to be done because the river has moved. So CMS is responding in one way with accountable care organizations. Now, this unlike a hurricane where it comes in overnight, CMS was aware that there was a problem. And so they started working on a solution when they created accountable care organizations. Basically, this is a group of companies, individuals, practices who are held accountable for the quality, cost, and experience of care for a population. You'll also recognize the term value-based care. That's what we're talking about here. And the ACOs were created to get rid of all that waste and make sure that we're still maintaining high quality, but lowering the cost of healthcare. The very first Medicare ACO was the Medicare Shared Savings. This came about in the Affordable Care Act in 2012, where the federal government offered financial incentives to clinicians to increase value. And it was essentially designed around primary care, since primary care providers can be the conductor in overall health. And so there were some incentives, and then they wanted specialists to also be a part of it. So now these ACOs are still in existence. There are different tracks for practices at different levels of sophistication, and I'll explain that here in a moment. I'll start first with what I mean by levels of sophistication, because you'll see this theme repeated throughout all the different types of ACOs that I'll talk about today. There's a glide path to value-based care. And on the very far left of this chart is fee-for-service. It's what we're familiar with, where providers, entities are paid for a visit. They're paid for a particular activity. Where we need to get in the nation is all the way to the right, where there is this skill set in managing a population, where we're focusing on not only high quality and overall satisfaction, but keeping quality high quality, low costs. So there are different steps. Not every provider is ready to kind of jump into this, but I'll just kind of overview the glide path where we go from paying a fee for service to paying for an activity or coordination, like Medicare Advantage does this as well. They'll pay for certain quality incentives like mammograms, annual wellness visits, certain things like that. Paying for performance, that's hitting a target. Have X% of your patient population have a colonoscopy. Bundled payments, that's hospitals are very familiar with those. It's where they bundle services around something like a hip replacement to watch the quality and the cost, excuse me. The pink boxes here, this is where we get into the real value-based, where it's really keeping an close eye on the cost and the quality. Shared savings, where if we hit a benchmark or a target, we can earn money. Shared risk is if we don't hit that benchmark, we might have to pay some money back. And then global payment capitation, that's the top, where that means that we have a smoothed out revenue trail where every month a certain amount of money comes in, regardless if there's a visit that month or not. So that's the overall glide path. Medicare shared savings has been on this glide path, but you'll see they're only in a certain area. Those tracks I mentioned before, it's how sophisticated a practice or an ACO might be. Enhanced is the most sophisticated, where there's upside and downside, where if we hit a benchmark, we could gain, or we might have to pay back some money. Though there are basic tracks that have a little bit less of a risk, and CMS is supporting practices and ACOs in their journey to value-based care. So you might be wondering, who decides the track in the MSSP? Well, the ACO does. CMS will sign a legal agreement with, so the ACO will sign a legal agreement with CMS, and then the ACO chooses which track they want to be in, the most sophisticated, which is enhanced, or a lower track, basic A, B, C, or D, or E. And then the ACO will go and partner with clinicians, and they'll choose those clinicians who are ready for value-based care. And then the ACO will sign those agreements with those practices, and they will become participants. So that's pretty much how the track is chosen. There's a lot of analysis that goes on behind the scenes, but for the most part, the ACO will choose the track. But what about all that blank space here? There are several areas, and actually CMS is well aware, is that they have to meet clinicians where they are on their glide path. Some clinicians are ready for capitation. Other clinicians are still trying to get their arms around managing that population, and then attaining measure targets might be the best place for them right now. So this is where we get into the other ACO models, because the Innovation Center, that is the department within the federal government that's introducing new models. And those models are to support clinicians on their journey. They are the research and development arm of CMS. And so this is through this department, they create models, and the rules are not public. You can't Google those. It's basically shared with those who sign up to participate. And CMMI will then work with ACOs and practices on their journey. And you can see here, they're filling in those blank spaces. CMMI has introduced ACO Reach in the global, up at the very top here with global capitation. They've also introduced Making Care Primary, which you may be hearing from your colleagues. So I've got a slide on that. There's a guide model and ACO PC Flex. So you can see CMS is doing what they can to meet providers where they are in their journey. Now, all these new models are based on the strategic plan. This was introduced in 2021, and this icon right here, these 5 pillars, this is how the federal government feels that they're really going to bend the cost curve. And they built goals around driving accountable care, advancing health equity, being innovative, addressing affordability, and then CMS wants to really partner with providers to make sure that they're going in the right direction and that they don't build another bridge that doesn't actually cover anything. So it's a true partnership. And through this, what CMMI is doing is they're really setting some very bold goals. This is the one that's the most bold, driving accountable care. They've said 100% of Medicare patients will be in a care relationship for accountability for quality and total cost of care by 2030. 100%. That means every single traditional Medicare patient will see a clinician who has to think about cost, not only cost, but and they'll also have to be thinking about quality. 100%. That is such a bold goal. So how do we get there is through these innovation models. Another goal that CMMI has set, and that is bringing in health equity. Every new model from now on out through I don't know how long, every new model from here on out will include an element of health equity, where we're embedding health equity in every aspect. And you'll see that here in this next slide, where we're going to talk about the models and how they've evolved. CMMI, that department, has really done a good job of learning from other models and then evolving them into new and improved models. At the base of this pyramid, you'll see here is Medicare shared savings. That's still active. Then you'll see here Pioneer ACO, Next Gen ACO, or GPDC, known as Global Professional Direct Contracting. If you've heard any of your colleagues mention those before, those are ACO models that have been active and have since sunset. But we do have a model that's active right now, and that is called REACH. And they actually embedded the word equity right in the name. They've evolved the global and professional direct contracting model into REACH, and this began in just 2023, or I should say the evolved version began in 2023. It's the ACO realizing equity, access, and community health. And this is definitely where the CMS has put a substantial way of measuring health equity and involving health equity in an ACO model. A little bit more about what this model is. So what they've done is their social determinants of health survey tools, and CMS has also evolved the benchmark, or that financial target we talked about earlier. They're adjusting that based upon health equity. They're taking a look at your patients in your panel and looking if they live in an area that has a high deprivation score or if they're dual eligible. And those things are taken into consideration when setting a target for overall cost of care. And so this is also a model where CMS has brought back capitation. This is a better version than the one that happened in the 1980s. This version of capitation does more in the way of smoothing out revenue and definitely incentivizes to take care of a panel of patients. The only thing is that with these innovation models is that they have a discrete application period, and when that ends, it's over. So REACH is the same. There's no way to apply. So the only way to actually participate in this model is to join an ACO that already has a participation license, essentially, to be a part of REACH. Now, this program is slated to end at the end of December 26. What we're anticipating is that CMS will either launch a new innovation model, or they might incorporate elements from REACH into traditional Medicare. We'll just have to wait and see. But overall, it's around the corner. We really do need to be looking forward and paying attention to what the next step is, because there is little time for CMMI to test new models. So here on this chart, you'll kind of see a lot of acronyms, and I'll go over some of these in the next slides too, is that in 2024 here this year, we have MSSP is still active, REACH is still active, Making Care Primary is appearing, and the guide model is making its debut. By the time we get to 2025, we're going to be introducing the ACO PC Flex, and I'll explain what these are here in a moment. And then right around the corner is 2030. We also have to keep a keen eye towards the next year. So here we are in May of 2024, and CMS has a deadline in August for us to determine who's going to participate in the ACO in 2025. So keep an eye out. And if you're thinking of being a part of an ACO, those decisions have to be made in the summer for next year. So let's talk a little bit more about those acronyms and those other ACOs. Making Care Primary. This is the longest model yet. It's actually a 10.5-year model, and it does begin this year. The application window is opened and closed. So if your practice isn't already in, there's not really a good way to join, because CMS requires everybody to bill under the same tax ID number. It's also offered in a subset of states, not all of the states. So they're testing certain components, and again, health equity is appearing. See those icons there to the right? CMS wants to make sure that they're watching health equity, and they're using this model to partner with practices that need a little bit of help. Remember, this model appears a little bit lower on that on the glide path to value-based care. They're assuming practices that are appealing, would like to be in this model, need a little bit more assistance. And so CMS is going to do that, provide these three tracks, and also they will have a dedicated advisor to help them through this particular model. So another model is the guide model. I don't have a lot on this slide because this is one that's very specific to a condition that focuses on dementia. So practices that have a large panel of dementia patients might benefit from this. It's an 8-year model that also launches this year. And there is a good website for all these details because CMS wants to really focus on that care delivery for patients with dementia. So that was a unique approach to taking care of a particular panel of patients. The newest model that you might be hearing, and you can see, look, all 5 of those panels or pillars from the strategic plan appear here. And this is the ACO Primary Care Flex. This is a 5-year model. It's being announced, and it starts actually in January, and it goes until 2029. This is interesting because what CMMI did here is, instead of having an entirely freestanding program, they're connecting with Medicare shared savings. So an ACO has to already be in MSSP. And then once they're in that, they can actually express interest then to also join ACO Primary Care Flex. What that does is the Medicare Shared Savings Program is where the health equity rules come from and where different shared savings rules come from. But then saying you're interested in Primary Care Flex opens up advanced payment arrangement opportunities. And that would be capitation. And also CMS is going to offer an advance payment to cover administrative costs, an upfront check to help with those things. The issue here is that it's going to be a little bit competitive to get in. They're only going to limit it to 130 ACOs across the nation. So those applications are also due in this summer. And you can see the model goals here. Obviously, they want to improve the patient experience, and they want to enhance the primary care payment and also narrow disparities. They want to really focus in on those health outcomes. So that is the ACO Primary Care Flex. And that was a kind of a speedy way to go through some of these ACO models. But in a nutshell, you might be wondering, are these ACOs even here to stay? Absolutely, yes. But the future is going to look different. The future is going to look different with health equity and the way we interact with other models and with traditional Medicare. So I'll leave you with this. There are some key takeaways here. The first one is, we just covered that, is that ACOs are here to stay. Some models may be phased out, but successful elements will be incorporated into the future of Medicare. And those innovation models, they do give ACOs the freedom to choose program elements and then implementing those programs, like how to do a health equity plan before it's actually required of all of us. It's a good way to kind of practice. And so that actually lends itself to a really nice learning lab situation and time to perfect strategies and learn before Medicare is changed forever. And then I'll leave you with one last tip, and that is, if you are looking to be a part of an ACO in 2025, which may seem like a long way away, you might want to start thinking about that now, because August 1st is the deadline for ACOs to participate in any CMS model in the following year. So it's coming up quick.
Thanks, Beth, and thank you everyone for joining us today. There's going to be a short survey for you all as this webinar concludes, and an email coming tomorrow, which is going to allow for further feedback and questions. We'll see you next time.